Good evening. Good evening to all. Welcoming you for the integrated MCQ round. Today, I used to say bugs and drugs. That means microbiology and pharmacology. It's infectious disease, integrated rounds. Hope audio, video, everything is okay. Everything is fine. So I'm typing good evening to all. Yeah. So I'm formally starting the session. Good evening, everyone. So today we are going to discuss three important clinical dignity or clinical scenario. What you are going to do day-to-day practice also, it will be helpful. Another thing, facing the exams also, it will be very useful. Okay. So good evening, Dinesh, Abhishek, Ruchita. Very good, very good. So I'm starting now. Formally, I'm starting now. Good evening, good evening. Right. See here. An 18-year-old male in his first year of college presents to the casualty with fever and severe headache. Every line will give some clue to you. Some lines will distract you. So at the end of the first line, he may have some problem in the headache, fever, maybe CNS problem. Maybe, I'm not 100% sure, but at the end of every sentence, you must have some idea. He reports having unprotected sex with several partners over the past few weeks. Now you are diverting to sexually transmitted infections. Maybe, we don't know. So he may have meningitis or he may have CNS problem. He may have some sexually transmitted infection. The history as per this sentence. Upon examination, the male demonstrates knuckle rigidity and photophobia. That's all. Knuckle rigidity and photophobia are the classical features to diagnose meningitis. His past medical history is notable for a lack of vaccinations, beginning from infancy due to his parents' belief that vaccinations may cause autism. So, he is not vaccinated, or if he properly vaccinated, then disease may not occur. That's another clue. A lumbar puncture performed. Obviously, it is a CNS case, so autism is there. Sorry, a knuckle rigidity and photophobia is there. So lumbar puncture is performed. CSF analysis revealing 2000 nucleated cells per millimeter cube. 90% are neutrophils, cells. 10% lymphocytes. Glucose 30 milligram. So for that you should know at least the values. If you don't know the exact value, at least it is reduced or increased, that much you should know. The glucose is reduced, decreased, and the protein is 120, it is increased. So at least you should know the normal value. I will show it to you. The CSF gram stain shows 4 plus white blood cells and 4 plus gram stain, shown in the image. So see the image. What is the color of the image? Organism. The organism is pink color. So pink color represents, what is this? Pink color represents pink color represents gram negative. And see the shape, it is round. So gram negative cocci, what is the arrangement? See the arrangement. 2 pairs. So gram negative cocci in pairs you are seeing in the CSF examination. So with this, what is your diagnosis? With this clinical dignity, what's your diagnosis? 18-year-old. So he is an adult. Okay. And he is having knuckle rigidity and photophobia. features of meningitis, and not vaccinated. Not vaccinated. Very good, very good. People beautifully answering. So it is a case of meningococcal meningitis. It's a case of meningococcal meningitis. How I'm saying, it's based on gram stain. Is it only gram stain sufficient? So we may have some clues. We may have some clues. Two things you need to know about meningitis. One thing, what is the etiology? Whether it is bacterial, viral, fungal, like that. Second, in the etiology, suppose in case of bacteria, what are the agents are causing? How to identify with available clues. With available clues, that I am going to teach you another 5 to 7 minutes. Very good. Many people mention meningococcal meningitis. Good diagnosis. See the basic thing. This you should know. This very simple slide. CSF profile in meningitis. In case of bacterial meningitis, first thing you can demonstrate polymorphonuclear cells, neutrophils, first cells. All others, viral, fungal, tuberculosis, lymphocytes. That's the first clue if you say it's a bacterial meningitis. Number 2, glucose will be drastically decreased. Proteins are markedly increased. Protein and glucose, see the ratio. And the opening pressure is increased. Opening pressure is increased. If you say viral, proteins are normal, glucose is usually normal, lymphocytes are present, opening pressure also normal, usually normal. In case of fungal, the protein is mildly increased, glucose is mildly decreased, and lymphocyte and pressure will be increased. Tuberculosis is almost same, but tuberculosis you have lymphocytes. So what are the normal values of at least glucose, protein we should know? See here, opening pressure is 180. In bacterial meningitis, it will be 200 to 500 will be there. Protein usually 15 to 50, but bacterial meningitis it increased 100 to 500. Our people got 120 or something. Glucose normally 40 to 100. It will be reduced less than 40. Less than 40 in bacterial meningitis. In bacterial meningitis. Got it? So know the normal value. You know the normal value. Protein 15 to 50. Glucose 45 to 100. And usually WBC differential no predominance. But bacteria is having polymorphonuclear, 80% polymorphonuclear cells. 80% polymorphonuclear cells. But these people are having lymphocyte. Tuberculosis, fungal, viral, everybody is having lymphocyte. Everybody is having lymphocyte. So one point is over. Based on the polymorphonuclear cells and the increased protein level, decreased glucose level, we are concluding this is a bacterial meningitis. Number 1. Number 2, diagnosis. There are many methods are there. CSF, the basic one is gram stain. It's not very sensitive test, but very specific test. If organism is there, game over. So you find the organism gram negative cocci. But one more clue also there, based on the age. If it's a person is adolescent and adult, which organism will common? Usually cocci will common. Adults and adolescents, cocci will common. If it is a gram positive diplococci, it may be pneumococci. If it is a gram negative diplococci, it may be a meningococci. So adults and adolescents, remember 2 cocci, either pneumococci or meningococci. Both are capsulated pathogens. Both are capsulated pathogens for the both vaccine available. For the both vaccine available. Pneumococcal vaccine also available. Meningococcal vaccine also available. Okay. It is advisable, not in mandated our country. It is advisable to take meningococcal vaccine for adolescents and adults. See here. Yes, age-wise etiology. 0 to 4 weeks. The encountering agents are group B streptococci, E. coli, and listeria. We shortly call BEL. That's a mnemonic everybody knows. I used to teach in the regular class. Bell. Klebsiella pneumonia. Other people also there in the queue. 4 to 12 weeks. 4 to 12 weeks. Again, GBS, E. coli, Listeria. And there will be Neisseria is including Streptococcus pneumonia including. 3 months to 18 years. Neisseria and Streptococcus pneumoniae, Haemophilus influenza, especially 5 years, 7 years, Haemophilus influenza are there. Once the person is adult or adolescent, commonly we can see meningitis, Neisseria meningitis and Streptococcus pneumoniae. Streptococcus pneumoniae. 18 to 50 years. See who came first? Meningococci, pneumococci. That's all. Meningococci and pneumococci. This point I want to emphasize. If the person is adult or adolescent, you can get commonly meningococci and pneumococci. More than 50 years, pneumococci tops. I'm writing in a order of importance, order of hierarchy. This order of hierarchy. This they will ask based on the age. It gives a clue to you. Based on the age, it gives a clue to you. The person is 18-year-old. So common may be meningococci or pneumococci may be the common one. That's another clue. Another clue. So apart from that, another one table I want to show it to you because immunocompromised. This person is immunocompromised. Am I right or wrong? Because how we are saying immunocompromised, see the clue. See the clue. Unprotected sex with multiple partners. He may. Unprotected sex with multiple partners. He may. Chances to develop HIV. We don't know exactly. Assumptions. Sometimes assumptions may help. Sometimes assumptions may not help. Come back to here. Yes. Some important conditions. Please remember, these are all use clues to you. Every case, clues are important. In case of they mentioned immunocompromised, if they mentioned openly the immunocompromised, then pneumococci, meningococci, salmonella, everything is common. And many gram-negative bacilli are common. In case of trauma or post-neurosurgery, Staphylococcus aureus epidermidis, these people are common. Please remember, the total scenario is changing. Basal skull fracture, pneumococci, H. influenzae, group S, beta hemolytic Streptococcus pyogenes are common. CSF shunt, again aureus. See, if any surgery or any injury, gram-positive cocci plays a major role. Okay, gram-positive cocci plays a major role. How to diagnose? Always remember, first one is CSF gram stain microscopy. Next is you can go for CSF culture. CSF culture, but it may take 48 hours to get the report. It may take at least 24 to 48 hours to get the correct identification and the antibiogram, culture and antibiogram. Always the best one is antigen detection. It's a panel test. Antigen detection, it's a panel test. So this case also that's the best. You can do bedside. It's just to take 1 drop of CSF, 1 drop of the reagent, mix it. If agglutination clumps are there, it is positive. That is called latex agglutination test. It is available as a meningitis panel. Pneumococci, meningococci, Haemophilus influenza, Cryptococcus, like common meningitis causing agents, with one test is called panel test. You can identify the correct etiology. It is 6 to 8 organisms you can diagnose. 6 to 8 organisms you can diagnose. That is called latex agglutination. It's very specific and very good one. Latex agglutination test. It is latex agglutination test. So using latex agglutination test. Apart from that, we have ELISA and PCR. So these tests are applicable to all meningitis, usually all meningitis, and should not forget some viral etiology also. Viral etiology also. Many viruses may cause meningitis. Those were called aseptic meningitis, like herpes viruses, enteroviruses. Many of them may cause, but viruses commonly involved in meningoencephalitis. Meningoencephalitis. Okay. Do not forget fungal meningitis also. That is, Cryptococcus is the common agent causing fungal meningitis, and parasites also, including entamoeba. Many people are causing meningitis. Okay. So now you people diagnosed, and you know how to diagnose, how to arrive the diagnosis from the clinical history to laboratory, and you know the laboratory methods also, and ultimately what we need, management. So that management will be discussed by Dr. Ankit sir. Over to Ankit sir. I'm stop sharing my.
So I think I'm not now audible, sir.
Yes, you are audible. Proceed, sir.
Sir, I was just hearing your part, and I went to my nostalgic days of college. That how we used to teach. I used to learn microbiology. You have very nicely explained the treatment, how to diagnose meningococcal meningitis. But now the real part also starts, that how to treat it also. So I'll first tell you, if a patient of meningitis comes to you, we don't have much time. As the sir has explained, we will obtain lab CSF sample, we will send for the lab culture. It will take 2 days. But remember, meningitis is an emergency. So as soon we will do a lumbar tap, we will take out a CSF sample, we will send to the lab. But generally the lab reports take at least 2 days, and especially for fungal and viral, it may take even longer also. So meanwhile, as it is an emergency situation, we will not wait, and we will start with certain empirical treatment. Now, what do you mean by empirical treatment? Empirical treatment means when you don't know the actual cause that which bacteria, virus or fungus is causing. So if a patient of acute meningitis comes to you, how to manage? We will start certain empirical treatment. Empirical treatment means we will start a combination of antibiotic that will cover almost all the etiological agents. Meanwhile, when our lab reports will come, when there will be lab confirmation, after lab confirmation, we will start with the specific treatment, that which specific antibiotics should be given for the treatment. So if you talk about, just a second, I'll remove this part. So if you talk about what are the drugs which we give for the empirical treatment of meningitis, we will write when a patient comes. So let's see which drugs we will give. So first of all, we will start 3rd generation cephalosporins, like the most commonly used is ceftriaxone, but there is another cephalosporin, that is cefotaxime. Cefotaxime has even better blood-brain barrier penetration as compared to ceftriaxone. Then we will also add vancomycin. We will also add ampicillin. We will also add ampicillin. You will add metronidazole. You will add doxycycline. You will add doxycycline. So why we are giving the combination of all these drugs? Let's understand. So this 3rd generation cephalosporin, as you can see, these 3rd generation cephalosporins, they will cover all gram-negative infections like meningococci. So the drug of choice for the treatment of meningococci or meningococcal meningitis is ceftriaxone. If ceftriaxone is not given, cefotaxime. You can write H influenza, especially in children. 3rd, Enterobacteriaceae family. So Enterobacteriaceae family like E. coli, Salmonella, Shigella, although they are less common cause, but remember in Enterobacteriaceae, one bacteria you will not write, that is except Pseudomonas. So these drugs are not effective against which gram-negative bacteria? This is an MCQ, that is Pseudomonas. So if you are suspecting Pseudomonas, when we will suspect Pseudomonas? If the patient is neutropenic or the patient is having some neurosurgery, recent neurosurgical intervention. So it's associated with surgical procedure, Pseudomonas, or the patient is neutropenic. In that case, you will not use ceftriaxone or cefotaxime because these two third generation cephalosporins are not effective against Pseudomonas. So now the question arises that which antibiotic you will give for Pseudomonas. So in that case, anyone who have an idea which antibiotic you will give? If ceftriaxone is not effective, then in cases of Pseudomonas, you will give ceftazidime. You will give which one? Ceftazidime. Or in ceftazidime resistant cases, most commonly we start ceftazidime. Otherwise, you can start meropenem, which is a carbapenem. So this is how you will cover Pseudomonas. Now, why we are giving vancomycin? Now, vancomycin is mainly given to cover, just a second, this vancomycin is mainly given to cover MRSA, that is methicillin resistant Staphylococcus aureus, because that is resistant to all cephalosporin, that is resistant to all penicillins like ampicillin. It is also given for streptococcal resistance cases like streptococcal pneumoniae, streptococcal agalactiaceae, streptococcal suis. So for those streptococcal resistant cases, we give vancomycin. Now, the third drug, ampicillin, a very specific drug and for a very specific infection where no other antibiotic is used is effective. It is the drug of choice for an infection or meningitis caused by Listeria infection. For Listeria, you add ampicillin. You have to cover it also, especially in small children also. Then why metronidazole? To cover anaerobic infection. Now, which anaerobic infection is implicated in meningitis? We will write like, just a second, yeah, like bacteroids, fusobacterium. So these meningitis cases occurs after if a patient has recently undergone some abdominal surgery and the patient is immunocompromised, anaerobes are present, it may lead to post-surgical or hospital-acquired also meningitis. Now, the last one is doxycycline. Why doxycycline? Because doxycycline is given for rickettsial meningitis. Rickettsial or tick-borne disease, tick-borne disease. So this is how we will give an empirical treatment with a cocktails of drug to cover possibly all infection. So now all these things are bacteria. What is left generally is virus. Hence, if you are suspecting HSV or herpes simplex virus, you will add acyclovir. Agree? And its congeners like famiciclovir, penciclovir. But the drug of choice is acyclovir, as simple as that. If you are suspecting some fungal infection, you will add a broad spectrum antifungal drug, that is amphotericin B. Amphotericin B. Now, what other adjunctive therapies you will give during treatment of meningitis? Apart from antibiotic, what other things you will give? You will give corticosteroids like dexamethasone. Why, sir? Because don't you think if there is meningitis, there will be inflammation? With inflammation, there will be fibrosis, there will be edema. So you have to reduce this fibrosis and edema. So to reduce this fibrosis and edema during meningitis, you will add dexamethasone. It's not an antibiotic, but we will give. And the second thing you will write, apart from dexamethasone, if the patient is having increase in intracranial pressure, due to increase in intracranial pressure, patient may have the pressure on the brain, sudden death may also occur. So you will tell the patient to hyperventilate. but you will give an osmotic diuretic, which is the drug of choice to reduce intracranial pressure, that is mannitol. So this is overall a broad treatment. When a patient of meningitis comes, we will give all these therapies. As simple as that. But now let's talk about what is the specific drug of choice for each bacterial infection. Agree? Each bacterial infection. So if I say the most common cause, as the sir has said, that is Streptococcus pneumoniae, Neisseria meningitidis. So first of all is Neisseria meningitidis. So it is a gram-negative infection. Tell me, gram-negative infection, the drug of choice for the treatment is? That is third generation cephalosporin, that is ceftriaxone or cefotaxime. It's a very good drug. Earlier the drug of choice was penicillin G. But the problem is now there is development of resistance against penicillin G. Hence we give ceftriaxone or cefotaxime. Now what is the drug of choice for prophylaxis? Now sir has said that this Neisseria meningitidis has a nasal carrier state. So you have to eliminate the nasal carrier state so that it does not spread. Now the drug of choice for prophylaxis of Neisseria meningitidis is no doubt ciprofloxacin. Ciprofloxacin is the drug of choice. If ciprofloxacin is not given in the option, then you can go with rifampicin. Now there was a recent NEET question in which both ciprofloxacin and rifampicin were given. Both options were given. Now you know which option you have to choose. You have to choose ciprofloxacin. But there is a point that ciprofloxacin fluoroquinolone is generally avoided in pregnancy and children. If the female is pregnant or there is a small child and you have to give prophylaxis in the close contact, in that case, in pregnancy and in children, you will again give the injections of ceftriaxone, intramuscular ceftriaxone, also for prophylaxis. Also for prophylaxis, you will give in pregnancy and children intramuscular ceftriaxone. But overall drug of choice for prophylaxis of Neisseria meningitidis is ciprofloxacin. Agree? So this is how you will treat Neisseria meningitidis infection. So this is the pharmacological part. Agree? So with the empirical treatment, I have already told you that which drug is covering which bacteria. That is why we are giving a cocktail of a bacteria. So if the lab confirmation comes and you find a particular bacteria, you will try to stop all other drugs and you will continue with that same drug. Agreed? So if the lab confirmation comes out to be MRSA, if it comes out to be MRSA, you will slowly stop all drugs and you will continue with vancomycin. So this is the approach how we manage the case of meningitis. Agreed? So now let's discuss about the second question. Back to you, sir. So I'm sharing the screen with you again. I have stopped sharing, sir. A prophylaxis beta we give in close contacts.
So a 16-year-old female perinatally infected with HIV, unknown to be poorly adherent to her medication regimen, presents to the emergency department with 2 weeks of fevers, worsening cough and respiratory distress and hemoptysis. So up to this 3 line, what we can conclude in the sense idea, HIV positive and poor adherent to the drugs, having some respiratory problem. So it may be an opportunistic infection because number 1, HIV positive, second, not adherent to drugs. That's indirect clue. She maybe have some opportunistic infection. We can have an idea up to this level. So I already told every end of every sentence, you need to think something. Second, she completed antibiotic treatment courses for community acquired pneumonia with both amoxicillin, clavinic acid and azithromycin without clinical improvement. So she took some antibiotic empirically, but clinical course is not improved. So here you can think of two aspects. One, she may have the etiological agent may be other than bacteria. The etiological agent may be other than bacteria, or the bacteria may be resistant to the drug what she has taken. It may be resistant bacteria, or it may not be a bacterial cause. So because of that, after taking antibiotic also, the clinical course is persisting. Next is, she is neutropenic gut, suffering from leukemia, malignancy, hematological malignancy, HIV positive, respiratory syndrome, and neutropenia, hematological malignancy. All you should think only few people. All these 4 points that take you to 2 people. She may have either Candida or Aspergillus. That's the clue. That's a common clue. Okay. So imaging studies reveals cavitary lung lesions of angio-invasive disease. The word is important. Every word is important. Cavitary, you may think tuberculosis also. Cavitary, you may think tuberculosis also, a common agent causing cavities. And angio-invasive, tuberculosis is not an angio-invasive disease. It's an angio-invasive disease. That means it can intrude into the blood vessels. Angio-invasive means it can intrude into the blood vessels. Septate hyphae or visualized. They gave the clue to you. The last line, at last, they gave the clue. It is a fungi because hyphae is a structure present in fungi. So definitely it is not bacteria. Cavity, don't think of tuberculosis. So it is fungi. Histopathology study shows fungi. Microbiological culture shown in the photograph. See, this is called LPCB mount. It's called LPCB mount. How it's look like. Okay. So this is Aspergillosis. So the question is only simple question. Diagnose and management, but diagnose not an easy deal. So after reading the question, before seeing the picture, you can come to diagnosis. Or another approach, first see the picture. What is it? This is Aspergillus. This is Aspergillus. In the Aspergillus, it's what type of Aspergillus, what type of species is important. The different species are there. Fumigators, flavors, Niger, different species are there. So you need to conclude which one it is. So after reading this, after seeing the picture, if you think Aspergillus, go and read the question. Definitely it will fit. So HIV positive, respiratory symptoms, especially hemoptysis, cavitary lesions. It produces cavitary lesions, fungal ball, sometimes that's called aspergilloma, fungal ball. It's an angio-invasive in nature, and septate hyphae. So what fungus it is? Based on septate hyphae, respiratory and neutropenia, hematological malignancy, every point is taking you to one fungus called Aspergillus. And based on the picture, you should see all the 3 together. Easily you can easy identification. See the image. There's some special images for you today. Yeah. See here. In the top 2/3, you have single row of phylites with conidia, chain of conidia, and it's a septate hyphae. It's suggestive of Aspergillus fumigatus. Top two-third of the vesicle. You have unicerate, single unicerate phylites. And chain of conidia. This is called Aspergillus fumigatus. So I used to tell in my class, fume hood. In the house where the fume hood is there, only in the top the fume hood is there. Every house, see, if you draw a house, only the top you can get the fume hood. So remember Aspergillus fumigatus. Second, in the vesicle, you can get biserate. See here exactly. I'm taking some other color for better contrast. See, bilayer, 2 layers are there, and full, it's almost full, 360-degree full. Full for flavors. Remember, full is flavors. And this one is black in color. This is biserate. Typically, it's look like Aspergillus flavors, but if it is black color, so we call it as Aspergillus niger. Aspergillus niger. So this morphological form, see here, top two-third, you can think of unicerate, top two-third, Aspergillus fumigatus. That's a common one. Here, 2 layers and almost full is Aspergillus flavus. Black in color is niger. This is my favorite picture. Many of my routine classes, you have seen the picture. See, this is flavus, this fumigatus, and the black one is niger. Okay. Niger. So this is you need to identify. I don't worry. Sometimes they will ask the etiology, maybe they give all Aspergillus. That time you need to identify which one. That time only this picture will be helpful to you. Second, sometimes they'll give the colony morphology. Please remember Aspergillus flavus. Flav means yellow color. It produces yellow colonies. And fumigatus is usually it produces tan green colonies. And niger, it produces black color colonies. Flav means yellow. Yellow, green and black colonies. See the image for you. Now you can tell this is Aspergillus fumigatus. Tan green. You can easily say this Aspergillus flavus. And this produces Aspergillus niger. Black colonies. I can zoom. See, tan green colonies, yellow flavus, and next one is niger. See here. Niger is black in color. Okay, good. So now you are, and it produces septate hyphae. See, septate hyphae, dichotomous branching, 45-degree angle branching, dichotomous branching. Septate hyphae with dichotomous branching. Right. Next is, so based on this, just a second. Yeah. So based on this, what's the diagnosis? Come back. Based on this, what's the diagnosis? Top two-third, unicerate. It is Aspergillus fumigatus. And the key point, what you need to remember, septate hyphae. Septate hyphae. Reduce the thickness. And it is angio-invasive nature. Angio-invasive nature. Every point is supporting. Next point, HIV positive is one among the opportunistic infection, neutropenia, and hematological malignancy like leukemia, immunosuppressed, and usually it associated with hemoptysis, and it very notorious in causing cavities. It causes cavity, and also in the pre-existing cavities like tuberculosis. In the tuberculosis, there is a pre-existing cavity. They go and settle happily in the pre-existing cavity. They forms aspergilloma or fungal ball. Fungal ball. Okay, these are all the features about aspergillosis. Aspergillosis. Lab diagnosis. Number 1, microscopy. In the microscopy, you can see, you can demonstrate septate hyphae with what branching? Dichotomous branching, 45-degree or acute angle branching. Anyone, acute angle branching. So septate hyphae with acute angle branching. Histoplasma. Shubham Dhawan has given us, why not it's histoplasma? Histoplasma causes fungal flu, but it's a dimorphic fungi. It's a dimorphic fungi. If you take the culture, it will be like this. It forms turbinate. It forms turbinate conidia or tuberculate conidia. The correct term is tuberculate conidia. With finger-like projections seen in histoplasma. You can think any of the differential diagnosis, nothing wrong in it, but you need to justify for your diagnosis. If there is a tuberculate conidia, I can go for histoplasmosis. Systemic mycosis, histoplasma, dimorphic fungi. I can go to that also. That's one among the agent causing HIV. I mean, that's one among the agent causing pneumonia in HIV positives, fungal pneumonia. But most common fungal pneumonia in HIV positives, pneumocystis. Do not forget that fellow also, pneumocystis. And Abhishek Rai already mentioned, sir, history of bat caves. Yes, history of bat caves, working in poultry. Okay, there are a lot of other things will be there. Good. So you need to have 360-degree approach. Nowadays the question patterns are not like that. Just reading 1 or 2 points, you cannot come to conclusion. You need to know 360-degree approach, integrated. That's only what we are doing here. Next is, after microscopy, you can go for culture. This will grow in any culture medium of fungus, Stabroid dextrosagar. I write shortly, Stabroid dextrosagar. There only you can get the different colors, yellow color, green color, and black color. I told you. Apart from that, rarely we have Elison PCR, not routinely used, because with the help of the two, you can diagnose. With the help of these things, you can easily diagnose. Histopathological will be helpful to you. Biopsy. Histopathological examination, you can demonstrate angioinvasiveness. Angioinvasiveness. And what stain we are using? Usually we can use Gomari methenamine silver nitrate. We have Gomari methenamine silver nitrate, different type of stains we are using. So now in this case, after reading all the things, after seeing the picture, you are concluding this as Aspergillus, and that also exclusively you are saying Aspergillus fumigatus because the picture they gave. Right, what else next? Next we need to manage the case because we already diagnosed. Clinically we suspected, laboratory confirmed. So we are going for diagnosis. So it's time to share my screen for Dr. Ankit to talk about the management of Aspergillosis. Thank you.
Welcome back, everyone. So, sir has very nicely explained about Aspergillosis. So, my work starts now. So, now I will be telling you how to manage Aspergillosis. Okay. So, if you talk about Aspergillosis, let's write Aspergillosis, or this fungus, causes which types of infection? And according to the type of infections, we will use the drug. Agree? So if you talk about Aspergillosis, sir has very nicely explained to you that it causes angio-invasive disease. We know this part. It causes angio-invasive disease. So this Aspergillosis, it causes various types of disease, and we will use the drug according to that. Okay. So just a second. So we will use the drug according to that only. So I'll just use the PPT part. Okay. So I'll share this one. So let's everyone make a heading Aspergillosis, and yeah. Aspergillosis. Now this Aspergillus causes mainly 4 types. We have to give treatment for mainly 4 things. One sir has already told you it causes angio-invasive disease. So let's call that Aspergillosis as invasive Aspergillosis. Invasive, and I'm writing the word A for Aspergillosis. Second, it is a very dangerous disease, very high mortality if it invades. Second, it may cause chronic pulmonary Aspergillosis, that it may remain indolent and remain in the lungs. Third thing, it causes one allergic reaction, especially if there is pre-existing cavities of like tuberculosis. That disease, sir has already explained you, known as ABPA. That disease is known as ABPA, that is allergic bronchopulmonary Aspergillosis. As simple as that. Lastly, if you have treated this Aspergillosis, but suppose the patient is immunocompromised, his CD4 count is very less, and that patient is at high risk of acquiring Aspergillosis, you have to give a drug for prophylaxis also. So prophylaxis with antifungal drugs are given in immunocompromised people. So these are the 4 main strategies, 4 main things which should come into your mind when you want to treat or manage Aspergillosis. Now, to make your life easier, remember the drug of choice for Aspergillosis is azoles. Drug of choice is azoles. What is azoles? I will be teaching you shortly. So azoles will be a type of antifungal drug. But remember, we use different azoles. For invasive Aspergillosis, the drug of choice is voriconazole. The drug of choice is voriconazole overall. If voriconazole is not given in the option, the second drug you can give is isavuconazole. Isavuconazole. Understood? So drug of choice for invasive is voriconazole. If voriconazole is not given in the option, isavuconazole. Now for chronic pulmonary Aspergillosis, again the drug of choice is voriconazole. I will write just the word vori. It is the drug of choice, voriconazole. But if voriconazole is not given in the option, then you will go by the answer itraconazole. Itraconazole. In this case, itraconazole. Done. Now, for allergic bronchopulmonary Aspergillosis, the drug of choice is itraconazole. It is not voriconazole. Itraconazole. That is the drug of choice. Agreed? That is the drug of choice. And for prophylaxis, again, the drug of choice is itraconazole. There is another drug that is posaconazole. Now remember, in India, we use itraconazole most commonly because it is a cheap drug. But remember one point, which is more effective. So which is a more effective drug? Remember, itraconazole is most commonly used for prophylaxis, but posaconazole is more effective for prophylaxis. It is better drug in preventing aspergillosis. Understood? So all azoles. Now after this, there are certain second line drugs we have. We have certain second line drugs. So second line drugs for this aspergillosis we will write is second line drugs. The first drug is liposomal or simple also amphotericin B. Liposomal amphotericin B. Second you will write is caspofungin and micafungin. So these are the second line drug, because sometimes we cannot afford, we cannot give azoles, it will have lot of drug interaction, lot of toxicity. In that case, you can give the second line drug. There is one advantage of using this liposomal amphotericin B. It is the only drug which can be directly given intrathecally into the brain if it is causing meningitis. And it is the only drug which can be given directly into the cavity, intracavitatory. Suppose there is a cavity in the lung, you can directly inject this amphotericin B there. Agree? So now tell me, is it simple or not? Agree? So I will now tell you a little bit about antifungal drugs. Okay, I will tell you a little bit about antifungal drugs. So remember, this is very important. So azoles are the overall drug of choice for aspergillosis. So if you see the structure of a fungi, except yeast-like fungi, almost all other fungi, they contain a cell wall. That cell wall is made up of beta-glucan, then secondly, it also has a cell membrane. We know it has a cell membrane. And this cell membrane of a fungi is made up of a steroid known as ergosterol. Ergosterol. Agree? Now the first antifungal drug we have, that antifungal drug which inhibited this cell wall synthesis is cell wall synthesis inhibitor. That drug inhibit one enzyme, beta-glucan synthase enzyme. So that antifungal drug which inhibit beta-glucan synthase enzyme is caspofungin and micafungin. Caspofungin and micafungin. I think we have written this drug in the second line drug. Second line में लिखा है हमने. So these caspofungin and micafungin, they inhibit cell wall, they inhibit beta-glucan synthase enzyme. Their group is known as echinocandins. Their group is known as echinocandins. As simple as that. Agree? Now these two drugs, they are only approved for treatment of two fungi. They are given only for two fungi. The first is, you can see C word and A word. That is candidiasis, invasive candidiasis. And second is aspergillosis. So that is why I have told you this drug out here, because we were discussing aspergillosis, only two fungi. Now let's come to this ergosterol cell membrane. So there is one drug which inhibits the synthesis of ergosterol cell membrane. That drug inhibits one enzyme, 14-alpha demethylase. Now the function of 14-alpha demethylase is to synthesize ergosterol. Is to synthesize ergosterol from lanosterol. So this enzyme is required. So if we will inhibit this enzyme, this ergosterol cell membrane will not be synthesized. So that drug which inhibits 14-alpha demethylase enzyme in fungus is azoles. I hope it's simple and easy. So all the drugs among azoles, they will end with the word azole. So the first drug is fluconazole. Now fluconazole is given for yeast-like fungi. So you know certain yeast-like fungi like Candida, Cryptococcus. So it is given for prophylaxis of cryptococcal meningitis. Drug of choice for the treatment is amphotericin B and coccidiomycosis. So one question comes, is Aspergillosis a yeast-like fungi? The answer is no. So is fluconazole effective against Aspergillosis? The answer is no. So the question is, which azole is not effective against Aspergillosis? That is, your fluconazole is not effective against Aspergillosis. Rest all other azoles are effective against Aspergillosis. So rest all other azoles, I have given you a mnemonic for, I will give you a mnemonic, that is VIPI. So these are the 4 azoles which are effective against Aspergillosis. V stands for voriconazole. Second is itraconazole. Third is osaconazole. And lastly, isavuconazole. So which 4 azoles are effective against Aspergillosis? VIPI. Fluconazole is not effective against Aspergillosis. I hope it's simple and easy. There is one last drug. That drug, what it will do, it will come and it will create pores on fungal cell membrane. So this drug will create pores on fungal cell membrane or ergosterol cell membrane. So that drug which create pores on fungal cell membrane is amphotericin B. Agree? Amphotericin B. I hope it's simple and easy. Now, what are the drawbacks of using amphotericin B? Amphotericin B is highly nephrotoxic drug. It causes allergic reaction and it causes anemia. Agree? What about azoles? You can see that azoles, they are inhibiting steroid synthesis. Don't you think these steroid synthesis will also be inhibited in humans? So tell me about certain steroidal hormones like testosterone synthesis will decrease. Hence, most of the azoles causes gynecomastia. Agree? They decreases estrogen. They will cause menstrual irregularities. Agree? Menstrual irregularity. Don't you think these azoles will also decrease glucocorticoid and mineralocorticoid synthesis? And azoles, they will lead to adrenal failure. So all these are steroidal hormone. Because of this reason, there was one azole which is now never used by injection for the treatment of fungal infection. It was maximum caused by ketoconazole. Rest all azoles can also cause, but it is maximum caused by ketoconazole. Hence nowadays ketoconazole is not used for the treatment of systemic or invasive fungal infection. Agree? So this is all about azoles and this is all about the treatment of Aspergillosis. So again, we are coming to our last question. We are coming back to Suria sir. So back to you, sir. I am sharing the screen again. Back to you.
Yeah, very good. We learn about the management of Aspergillus very elaborately. Thanks, Ankit. Now I'm going to share my screen. We're moving to third question. It's a final question. Hope now I'm audible. Yes, I'm audible. Check the A 65-year-old retired male police officer reports to an emergent care facility complaints of fever, sore throat, and shortness of breath, dry cough, and generalized muscle aches and pains. Oh my God. What you people immediately think? Old man, fever, sore throat, cough, and body pain. Definitely everybody will think now COVID-19. Yes or no? That only comes to your mind first. I will not say no, that's not a wrong clue. That may be the right way you are dealing. So at present, in practically, don't bother about the question. Practically, if you see a patient who came with cough, body pain, and respiratory distress, then immediately you can think of COVID. First you rule out, then go for the next. Nothing wrong in it. But the same strategy cannot applicable for you when you are appearing for exam. They may ask from anywhere. On examination, the patient is pale, tachycardic and tachypneic. Yes. Still our mind fixed only with COVID-19. His conjunctiva are congested and rales and wheezes are heard over both the lung field. Still, he is having some respiratory problem. Etiology may be virus because he is having body ache, other thing and all. Body ache and other thing and all. A chest radiograph shows diffuse bilateral infiltrates and a hemagglutinin inhibition antibody test is positive at high titer. So the last line, the full stop, they gives full stop your diagnosis. Hemagglutinin inhibition antibody titer positive. So otherwise you cannot come to conclusion. With this, it's a vague history. It's a vague history. You can think he's having respiratory illness. Even the same thing applicable to some bacteria also, some bacterial pneumonia also. But diffuse bilateral infiltrates, many people can cause pneumocystis, many viral pneumonias. Ground glass appearance may be seen in many viral pneumonias, including some fungal also. So here the laboratory which gives full stop to you is hemagglutinin inhibition antibody test, where you can get what is the diagnosis. With the help of that, I can say it is a case of influenza. Yeah, orthomyxoviral disease. Do not confuse influenza with influenza, Haemophilus influenzae. That's a bacteria. It's influenza, orthomyxoviral disease. What are the basic characteristic of virus? It is having segmented RNA. Sorry, why it is being very big? It segmented RNA. So it can undergo genetic reassortment. Genetic reassortment, and which is very severe, and may be the reason for pandemic. Today we are talking about the pandemic of corona, COVID-19. But you see the history, flu has a very good contribution for pandemic and reduction of population. We are comparing with flu, Spanish flu, the waves are there. So we are comparing with this flu with corona now. Corona also having waves. So don't underestimate. Learn the lesson from Spanish flu, like that. So genetic reassortment, which is very danger and which is the cause for pandemic, is antigenic shift. One more is antigenic drift, that may be mild. Antigenic shift. So what is antigenic shift? What are the important antigens? This virus has two types of antigens on the surface. One is called hemagglutinin. HA, we shortly call H, total 18 types. 1 to 18. The numbers are 1, 2, 3, 4, 5, 6 up to 18. Previously it was 15. After that they added. Now it is 18. Another one is neuraminidase. This is up to 11 times. Neuraminidase 11. N11. Hemagglutinin and neuraminidase. So influenza you cannot diagnose 100% with the help of clinical picture, because all viral pneumonias are, the presentations are almost same. Almost the presentations are same. So laboratory diagnosis also for imaging techniques may not help you. Imaging techniques you can say it's viral pneumonia. Even COVID also nobody gives COVID. They will say it's viral pneumonia. So only the laboratory test will confirm. So what is the best test to confirm? There are a lot of tests available. One is called antibody detection, hemagglutinin inhibition test. Hemagglutinin inhibition test. If the patient serum is having antibody, it will inhibit the hemagglutinin. One more is called neutralization test. These are all antibody-based tests. But ultimately, if you want to give the full stop for diagnosis of influenza virus, is RT-PCR. Confirmatory test is RT-PCR. Like COVID-19, RT-PCR. And ideal specimen, nasopharyngeal swab. Same. Ideal specimen, nasopharyngeal swab, and ideal test is RT-PCR. Even ELISA is not a very good test. They may be, you can use it as a screening test purposes. Number one. So you know what is called antigenic shift. Because of antigenic shift, we got the avian flu, swine flu, many things. Just this image will tell you. See here. This is called genetic reassortment. There is avian strain, there is some human strain, and the pig is the mixing vessel. Pig is the mixing vessel. You can get novel virus, which has the property of avian, which has the property of human, and which has the property of some pig, swine character. Swine character. So it has triple. 2 part of swine, 1 part of bird, and 1 part of human. We call it as swine flu. It's a pandemic. Previously we had avian flu. Swine flu is H1N1. Avian flu H5N1, like that. So every 10 to 12 years, usually they may have a pandemic strain. Pandemic strain, it's not 100% sure. It's not 100% sure, but usually is the case. So you know what is antigenic shift, abrupt change which leads to pandemic. Number one. You know what is confirmatory. And I take this opportunity to teach you one thing called phenotypic mixing. Sometimes they may ask. Please understand the concept. What is phenotypic mixing? 2 to 3 minutes or maximum 5 minutes I will teach this. This is very important. If one cell is infected by 2 viruses, again I'm telling, one cell is infected by 2 same type of viruses, they can exchange some characters. And they form new phenotype. Okay, so that is called phenotypic mixing. The phenotype got mixed, but when it multiplies, ultimately what the original genotype that will get expressed. the original genotype will be expressed. So phenotype will occur, phenotypic mixing will occur, but that's not permanent. That's not permanent. After that, the original genotype will express. See the image, you can get the idea. See here, it's a cell. Listen to me, it's one cell. It's infected with two viruses. One is called A, another one is called B. So A has this property, B has this property. So if these two are mixing, what are the possibilities? There are 6 possibilities are there. One, A original and B original. Otherwise, nucleocapsid is A and the envelope is B, A and B combination. Here nucleocapsid is A, the genetic material is A, and the envelope is B. So I can call it as this is AA because nucleocapsid also A, envelope also A original. Here I can call this as AB, A and AB because nucleocapsid is A, but the envelope is A and B. Here AB, nucleocapsid is A and the envelope is B. Like that. Here we can call it as BB. This is called B and AB. This is called B and A. Easy to remember. Easy to remember. So B nucleocapsid genetic material, A is envelope property. So there are 6 combinations are there. Don't worry. But when they express, when they're coming out of the cell, the progeny, always based on the original nucleic acid. This is A. What is the nucleic acid A will produce? The envelope for A. All are A. See, all 3 are A. Whatever it may be. When they express, they express an original. So this is called phenotypic mixing. Phenotyping, see here, everything is B. B original, all original. This property is seen in influenza virus. Phenotypic mixing is there. So the take-home message, they can have different type of phenotypes. That's called phenotypic mixing. That may occur, but that's not permanent. That's not permanent. When it expresses from the existing, the original one, the original nucleic acid. Okay, right. So, as per the questions, our diagnosis is it is influenza. I can't say it's swine flu. It is influenza because hemoglobin inhibition is positive. So we can say influenza virus infection. I cannot say it is swine flu or it is avian flu. But if the hemoglobin inhibition titer, if they are using specific for swine flu, that time I can say swine flu. Here the question not clearly mentioned. So I can say it's an influenza virus infection as your people told. It's influenza infection. Confirmatory test RT-PCR and genetic reassortment we have discussed. Genetic reassortment leads to new virus. So existing vaccine, existing antibody, herd immunity, nothing will help you because that virus which comes is totally new virus. Okay, that's the reason it causes pandemic very easily. So with this, I can stop here and I request Dr. Ankit to continue the management. They can come back for prevention. Thank you. I'm stopped sharing my screen. Yes, Ankit.
So thank you, sir, very much. So now I will be starting with the management of influenza. So what are the different anti-influenzal drugs we have? So this is overall the structure of influenza, which I have no idea. For me as a pharmacologist, I have only 2 concerns in this whole structure of influenza. Only 2 structure I want to mark. The first structure I want to mark in this influenza virus is this neuraminidase. I want to mark it. And the second thing I want to mark in this influenza virus structure is this M2 ion channel. These two things I want to market. Rest, whatever is there, it's expertise of Suria, sir. Okay. So we have two types of anti-influenza drug. The first is neuraminidase inhibitors, and another one is M2 ion channel or proton channel inhibitors. So we have two types of anti-influenza drug. As simple as that. So let's write anti-influenza drug. So what are the two different anti-influenza drugs we have? Okay, just a second. So, yeah. So we will write, we have two types of anti-influenza drugs. The first is M2. Instead of ion, I will use a word proton because proton is an ion. M2 proton inhibitors. And the second one we are having is neuraminidase inhibitors. Okay. Now, if you inhibit M2 proton on a influenza virus, what will happen? Remember, when influenza virus, suppose this is an influenza virus and this is the envelope with spike proteins. When it enters into the human cell, this influenza virus envelope is uncoated. इसका envelope बाहर निकल जाता है. Envelope is uncoated. This M2 proton ion is required for uncoating of virus of the envelope of the virus. So if you inhibit this M2 proton, these drugs will inhibit uncoating of virus. So if there will be uncoating of virus in envelope, can we say that these drugs will decrease entry of virus into the human cell? Agree? What about neuraminidase inhibitor? Now this influenza uses the host DNA and it forms many copies. And then these proteins are assembled again. And this influenza virus goes outside. To go outside the human cell, it requires an enzyme, neuraminidase enzyme. So can we say that neuraminidase inhibitors, they inhibit release of virus out of the human cell? So can we say that they will decrease exit of virus? So M2 proton inhibitors inhibit entry of virus. Neuraminidase inhibitors, they inhibit exit of virus. As simple as that. Now what are the drugs we have among M2 proton inhibitors? Very simple to remember. The first drug is amantadine. And the second drug is rimantadine. Okay? Amantadine and rimantadine. So both drugs are ending with the word mantadine. What about neuraminidase inhibitors? Very simple to remember. Oseltamivir, zanamivir, and tiramivir. So this is a very frequently asked question. Tiramivir. So these drugs are ending with the word mivir. These drugs are ending with the word mantadine. As simple as that. Easy. Now let's see against which type of influenza they are effective. Agree? So if you talk about amantadine and rimantadine, these drugs are effective against, I'll use a different dark color. Let's use blue. So it is effective against influenza type A. Okay? They are not effective in influenza type B. Now you know a very famous swine flu. Tell me, swine flu is caused by influenza A or B? Remember, swine flu is caused by influenza A. Which type of influenza? H1N1. H1N1 causes swine flu. Agree? Now these drugs are effective against influenza A. They are also effective against influenza B. They are also effective in resistant cases of amantadine and rimantadine. They are also effective against H1N1, that is swine flu. They are also effective against H5N1, that is avian flu. So tell me, which is the more effective drug? Which drugs are more effective? So now we can say that neuraminidase inhibitors, they are more effective drug. Because of this reason, we will mark that this neuraminidase inhibitors now are the overall drug of choice for influenza infection. Amantadine and rimantadine now are not the drug of choice. So the drug of choice is neuraminidase inhibitor. Very good. Let's talk about their first adverse effect. Okay. So first I will be telling you about oseltamivir, which is the neuraminidase inhibitor, oseltamivir. Now, what is the route of administration? Oseltamivir is given as an oral tablet. Agree? Zanamivir, you can identify from their name also. This question has been asked. It is given as a nasal spray. Zana, na means nasal. The third drug which has been developed is piramivir. Piramivir is given parenterally. Parenteral means it is given IV, especially those patients who have been admitted to ICU. Agree? So it is given IV. Now the overall drug of choice is oseltamivir. Its dose is 75 milligram, which is given for 5 days. Which is given for 5 days. 5 days BD for treatment, which is given 7 days OD for prophylaxis. So oseltamivir is the overall drug of choice. It comes with the brand name. It is also known as, it comes with the brand name Tamiflu. You must be aware. What is the brand name of oseltamivir? Tamiflu. Now this zanamivir and this piramivir, these drugs can be given in resistant cases of oseltamivir. They can be given in resistant cases of oseltamivir. So this is the dose and the treatment of influenza. Oseltamivir dose you have to remember. Agree? I hope it's easy and simple to remember. Now, what about amantadine and rimantadine? These drugs are now less commonly used. So the main side effect of amantadine and rimantadine is it comes in brain. Their main side effect comes in brain. Why? Because amantadine and rimantadine in brain, they increase dopamine activity. They increase dopamine activity. Because of increase in dopamine activity in this cortical area, it causes a side effect of psychosis. In psychosis, you know, there is hallucinations, delusions, and seizures. Agree? Now, can you tell me, because amantadine and rimantadine increase dopamine activity in brain, can you tell me one another use of amantadine? One another use of amantadine? If dopamine level in the basal ganglia reduces, you know, it causes Parkinson's disease. Basal ganglia में जब dopamine कम हो जाता है, it reduces, it causes Parkinson's disease. So one point, which antiviral drug has been approved for the treatment of Parkinson's disease? The answer is amantadine. Because it increases dopamine level in the brain, hence it has been approved for the treatment of Parkinson's disease. Agreed? Amantadine. But if dopamine increases excessively in cortical area, it causes psychosis. That is why antipsychotic drugs like haloperidol, chlorpromazine, they block dopamine receptor in cortical area. Antipsychotics, they block dopamine. And their side effect is Parkinson's disease because they reduce dopamine activity in basal ganglia. That is a separate topic in CNS, we will discuss it. Now, one more side effect of amantadine I want to tell you. In periphery, this amantadine and rimantadine in periphery, because of this dopamine, they cause vasodilation. Because of vasodilatation of veins, there will be blood collection and you will feel blue blood. So they will cause one disease known as libido reticularis. Amantadine and rimantadine in periphery causes libido reticularis because of vasodilatation. So what is libido reticularis? You can see this pattern. This is a very frequently asked question. That you can see this reticular means net-like cyanotic discoloration around the pale central. So you can see this pale centrals. So this is reticular pattern, net-like pattern you can see. Net-like pattern of discoloration, blue discoloration. So this is known as libido.
It's 11 o'clock.
Libido means bluish or purplish color. Libido का मतलब ही यही है. Reticularis, you know, is net-like pattern. Libido reticularis is the side effect of which antiviral drug or which anti-Parkinsonism drug? The answer is amantadine. So libido reticularis is the side effect of amantadine. So these are the very favorite MCQs which you must remember. Okay. And by this libido reticularis, I conclude my session. And back to Suria sir also. I am taking Suria sir again.
Yeah. Hope you people enjoy the clinical vignettes and the prevention vaccine available. We have killed vaccine intramuscular available, and the swine flu we have nasal spray Nasavac vaccines also available. Don't worry. Hope you people all enjoyed 3 important cases. One from fungus, one from virus, and one from bacteria. Almost we covered all the aspects and different systems also. Any doubts? You can just, we are waiting for in the chat box for next 2-3 minutes. See your doubts. We clarify your doubts. We'll wait for 1 or 2 minutes.
Yeah.
You can type your notes. Okay, people start saying thanks. That means there is no doubt. Okay, so thank you all. Thank you very much. Stay tuned for this kind of many other integrated sessions, because nowadays everything is integrated based. Here the one center, we are discussing everything with the concerned specialty experts, so you can really feel it. Thank you very much, and thank you, Ankit, also.
Thank you, sir. Thank you very much. Good luck, everyone. Have a good night's sleep. Thank you very much, sir. So I also learned a lot today. So thanks a lot.